So moving to the next structure of tooth, that is pulp. Pulp is a soft connective tissue and it is present within the pulp cavity. That is, the rigid confinement of pulp within the hard structure makes the tissue very unique. And the one which is present in the crown area is known as corona, and the one which is present in the root is known as radicular pulp. The zones of pulp involve odontoblastic zone, where the odontoblast were arranged in a palisading fashion, and there exists a cell-free zone which is devoid of cell, and cell-rich zone which consists of fibroblast and undifferentiated mesenchymal cells. Then comes the pulp core. Okay, and the odontoblast will be in different phases throughout the odontoblastic zone of pulp. Either it could be active or transitional or resting. So, how do you differentiate all these three under microscope? In the active cell, it will be elongated with a basophilic nuclei, and there will be abundant organelles and presence of vesicles. Whereas in translational, it will be narrow with fewer organelles and autophagic vacuoles. And in case of resting, it is devoid of organelles with more basophilic nuclei and lipid-filled vacuoles. The cells of pulp includes fibroblast, undifferentiated mesenchymal cells, lymphocytes, macrophages, dendritic cells and few fibers. Pulp is very unique because it lacks elastic fibers. So, fibroblast is the most common cell present in the pulp. It is stellate shaped and it helps in the inflammation and healing. Whereas undifferentiated cells were polyhedral in shape with an oval nuclei, and they are said to be totipotent, that is, they can be differentiated into fibroblast, odontoblast and many. Then moving to macrophages. Macrophages are large cells with granular cytoplasm and has a blunt process. They contain phagosomes, that is, it just have the debris after phagocytosis. Then comes the dendritic cells. These were associated with endothelial cells and they present antigen to T cells, and lymphocytes, eosinophils and plasma cells were present during any inflammation. Then coming to fibers, pulp consists mainly of type 1 collagen fiber, and young thin fibers were known as fibrillin, which later upon age leading to formation of dense fibers. Moving to matrix and ground substance. Pulp consists of mainly of type 1 collagen and traces of type 3, and the ground substance consists of glycosaminoglycan glycoproteins. Since the glycosaminoglycans is hydrophilic, okay, it will take up the water and gives a gel-like appearance, and it is responsible for the high tissue fluid pressure of the pulp. So, development of pulp. Lifespan of deciduous teeth takes up to 8 years and 3 months, whereas development of pulp in a permanent teeth takes 12 years and 4 months. So, these phases depicts the development of pulp in a deciduous tooth. There are 3 phases. The first phase being phase of growth, which occurs for 1 year, and it starts from the beginning of root formation to root completion. Then comes the phase of maturation, which occurs for 3 years and 9 months, and it is after root formation until root resorption. Then comes the phase of regression, which occurs at 9 years and 6 months. This depicts beginning of tooth resorption till tooth exfoliation, whereas the permanent teeth develop 12 years and 4 months. So, what are all the functions of pulp? The first most important is induction. This pulp analog will help in the differentiation of dental lamina, or it will determine the tooth morphology by interacting with the oral epithelium. Then formative, it helps in the formation of dentin, like either reactionary or reparative, any stimuli, it will start forming or start responding to it with the formation of dentin. Then nutritive, the vascular supply of pulp gives nourishment to the dentin via odontoblast. And it is protective also, because of the pain perception to all stimuli, it is giving a protective nature to the tooth. Then comes the defensive, as I already mentioned, stimulus or any irritation, there will be formation of reparative dentin. Moving to clinical consideration, there is something called pulpitis. Itis means inflammation. So, it is nothing but inflammation of pulp. It could be either reversible or irreversible depending upon the range of stimulus. Then pulp polyp, this usually occur in children and young adults, when the pulpitis will be reflected as a red mass of granulation tissue over the occlusal aspect. Then pink tooth, which is due to the outward resorption of the dentinal pulp, and the inside dentinal walls and the inside pulp will be seen through the translucent enamel, and thus teeth is known as pink tooth, that is nothing, the internal resorption. Then pulp stones. Pulp stones are nothing but calcification which is present in the pulp chamber. It could be either true or false. It is called true when it mimics the dentin, that is it should have dentinal tubules. Otherwise, just concentric layers of calcification is called as false denticles, and when it is free in the pulp chamber it is called free, and when it is attached to the dentin it is known as attached denticles. Then coming to diffuse calcification, where there will be calcifications present diffusely throughout the pulp chamber. Age-related changes in pulp is one of the most important clinical implication, because as the age goes, there will be reduction in the size of the pulp organ due to the deposition of secondary dentin. You can clearly see the difference between the pulp at the young age and the difference at the older age. There will be more deposition of secondary dentin, leading to the regression of the pulp. Moving to cementum. Cementum is another hard avascular connective tissue covering the roots. It consists of 45 to 50% of inorganic and 50% of organic material. As in the pulp, it also contains mostly of type 1 collagen and a specific unique protein, that is cementum derived attachment protein, which helps in the attachment of the cementoblast during formation. So, the thickness varies. It is thinnest at the CEJ, that is where it is 20 to 50 micrometer, and it is very thickest at the root apex where it is 150 to 200 micrometer. The incremental lines were known as incremental lines of Salter, that is the rhythmic deposition of cementum. And there is something called an hyaline layer, which is a structureless layer. It is neither depict dentin nor cementum. It will be seen in the apical 2/3 of molars and premolars, but research have told that it is of dentinal origin. So, moving to the cementum formation. So, these pictures will clearly tell you the formation of cementum. In the first picture, the inner enamel epithelium and outer enamel epithelium proliferate downwards, leading to formation of Hertwig's epithelial root sheath that induces dental papilla cells to form odontoblast, okay, here. And in the second picture, this Hertwig's epithelial sheath cells break. Then it will induce dental follicle cells to differentiate into cementoblast. Then in the third picture, these cementoblast will start forming cementum overlying the radicular dentin. So, types of cementum. Based on cellularity, it is acellular and cellular. Acellular means absence of cementoblast and cellular means presence of cementoblast. Based on the time of origin, it is either primary or secondary. Based on the presence of collagen fibrils, it is either afibrillar or fibrillar. Afibrillar, again absence of fibrils, and fibrillar, presence of fibrils. Based on the origin of matrix fibers, if it is extrinsic, they were formed from the periodontal ligament, and if it is intrinsic, within, so it is formed from its own cementoblast, and mixed fiber cementum, which is formed by both PDL and cementoblast. So, the differences between acellular and cellular cementum being acellular cementum is first formed, whereas cellular cementum is formed after acellular cementum. So, the deposition rate is very slower when compared to cellular cementum in acellular cementum, whereas in cellular cementum the deposition rate is really high. That is why the cementoblast getting entrapped within it, and there will be more amount of cementocytes seen in the cellular cementum whether there is no cementocyte seen in the acellular cementum. Since there will be a slower deposition, the incremental lines present in the acellular cementum is very regular, whereas in case of cellular cementum it is irregular. The width is constant. Here the cellular cementum, the width is variable, and acellular cementum is present in the cervical third, whereas cellular cementum is present in the apical and interradicular area. And sharp piece fibers were well mineralized in case of acellular cementum. It is partially mineralized in case of cellular cementum. There is something called acellular afibrillar cementum, which is devoid of cells, devoid of fibrils, which is due to the premature loss of reduced enamel epithelium. Hence, it is deposited as a thin layer on enamel at the cervical region. And cementoid is unmineralized matrix, which is not found in the acellular extrinsic fiber cementum. So, this is the picture showing you acellular cementum and cellular cementum. In the acellular cementum, there is no cells throughout the cementum, whereas in the cellular cementum, you can see cementocytes. So, how do you differentiate between a cementocyte and an osteocyte? Cementocyte lie in a lacunae with a canaliculi radiating towards PDL, whereas in osteocyte, it will be radiated throughout all the surface. Moving to the cemento-enamel junction, that is the junction between cementum and enamel. So, this is of three types. The one being bud joint, which is 30%, that is the cementum and enamel will meet in the same point. Okay, and there is something called gap junction, which is only 10%, that is there is no relation between the cementum and dentin, and hence there is no cemento-enamel junction in such cases. The most common is the cementum overlapping enamel, which is seen in the 60% of population. So, moving to the functions. Functions of cementum involves anchorage, that is it will anchor the teeth to the PDL. Okay, it will anchor the teeth to the PDL. Then comes the adaptation. If there is any occlusal loss, it can be compensated by the formation of cementum in the apical region. So, that is adaptation. Then something called repair. Repair is of two types. One is anatomic repair, the other one is a functional repair. When the cementoblast can form cementum which will maintains its previous length and width, then it is known as anatomical repair. And functional repair, when there is a bay-like recess occur and the bony projection will be starting from the periodontal space to compensate that, then it is known as functional repair. Clinical implications: hypoplasia or aplasia of cementum is nothing but absence of cementum, which is seen in condition called hypophosphatasia, where there will be complaint of premature exfoliation of teeth. And hypercementosis, which is nothing but the increased cemental deposition. It could be either localized or it could be either generalized, as seen in Paget's disease. So, the width of the cementum will be more than 250 micrometer, and since the cementum is avascular, the orthodontic movement is possible, that is the compression and the tension which were given during the orthodontic treatment is well taken up by the cementum because it is avascular. Moving to the another peculiar soft tissue, that is periodontal ligament. It is a specialized connective tissue and the width of the periodontal ligament is of 0.15 to 0.38 mm. It maintains its width instead of being squeezed between the two hard structures, that is, one is cementum and the other one is the alveolar bone. Okay, though it is present in between these two hard structures, it still maintains its width and it still maintains the homeostasis, and that is the speciality of the periodontal ligament. So, how do they develop? The perifollicular mesenchymal cells of the dental follicle will have the synthetic activity. They gain polarity and they will start synthesizing as the root formation continues, and the cells gets elongated with more amount of organelles and they will become an active cells. From polarized cell it will become an active cell, then later leads to deposit collagen and glycoproteins, which are the contents of the periodontal ligament. So, first developed fiber is the alveolar crest fiber. So, these fibroblasts elongates and they align in an oblique direction to the long axis of the tooth, and they secrete collagen fibers, and once the tooth starts erupting, they will be formed as an alveolar crest group of fiber. Then, how do other fibers form? Small fine fibrils from the cementum enters the PDL space. So, thin collagen fibrils from bone enter simultaneously, that is, few fibers from the cemental side and few fibers from the bone. Then fibers in coronal third will establish once initial contact is formed, and that forms the horizontal fibers later, and oblique fibers mature with definitive occlusion, and subsequently the apical fibers were formed. So, the cells of the fibroblast include synthetic cells, that is, fibroblast, osteoblast and cementoblast. Then resorptive cells, osteoclast, fibroblast and cementoclast. Then you have something called progenitor cells, epithelial cell rest of molasses, mast cells, macrophages and eosinophils. These are the inflammatory cells. Okay. So, moving to the fibers, these collagen fibers will present as bundles and they are known as principal fibers. Sharpie's fibers were the one which were embedded from cementum to the alveolar bone, which is completely mineralized in case of acellular cementum, and in case of cellular acementum area it is partially mineralized. So, this is the picture showing dentoalveolar, that is the first formed fiber, then horizontal, oblique, apical and interradicular fibers is present only when there is an multi-rooted teeth. So, each fiber have its own function. The alveolar crest fiber, which runs downwards and outwards and insert into the alveolar crest. That is why it is termed as alveolar crest fiber, and it prevents extrusion of tooth from the socket, and it also resists lateral tilting and intrusive tooth displacement. Then comes the horizontal. Horizontal is limited to the coronal third and it runs at right angles. It resists horizontal and tipping forces. Then comes the oblique. Oblique is the most numerous fiber, that it covers the 2/3 of the length of the tooth and it runs in an oblique direction. It is the largest group I mentioned just now, and it resists the vertical masticatory forces and thereby preventing intrusion of the tooth. Then comes the apical, which is present in the root tip, and it fans out in an irregular fashion and is inserted into the apex of the socket. It is not found in incompletely formed roots and it resists vertical, luxative and twisting forces. Then comes the interradicular. It is present only in the multi-rooted teeth and it is present in the interradicular septum, and it resists vertical and lateral movement. Tipping, torquing and luxation is also resisted. These type of fibers will be lost in case of periodontal disease. So, moving to the function, it is supportive, that is, it supports the entire tooth to present inside the alveolar bone socket, and it is sensory, it has proprioceptive receptors. It is homeostasis, that is, it maintains its width throughout, and there is no formation of hard tissue, though it is squeezed in between the two hard tissues, and it helps in the eruption of tooth. It provides nutrition and it also withstands mechanical forces. So homeostasis, which is a special feature of periodontal ligament, how does it occur? MSX2 and TGF beta will downregulate osteogenic differentiation, and matrix GLA proteins, which are the main inhibitor of mineralization, will maintain the periodontal ligament in a soft tissue range. It will not allow them to calcify. Okay, there is no calcification because of these three products, and the balance exists between bone silo-protein and osteopontin to maintain its width and also to maintain homeostasis. Clinical implication: any periapical pathology will destroy the apical fibers and leads to formation of periapical cyst or periapical granuloma, and guided tissue regeneration have been recently used to correct any PDL destruction. Again, the orthodontic tooth movement depends on cementum, bone and also the PDL. PDL is the one which withstands compression and tension which were produced during orthodontic treatment. Moving to the alveolar bone. Bones of the jaws containing sockets for the teeth. Outer cortical plate, otherwise called as compact bone, which consists of circumferential lamellae that are tightly packed around the Haversian canal. Bundle bone is nothing but the part of alveolar bone where the principal fibers of PDL were anchored. So radiographically it is depicted as lamina dura. The supporting alveolar bone consists of cortical and spongy bone. So there is something called type 1 and type 2, that is the interdental and interradicular trabeculae, where ladder like in case of mandible and it is irregular in case of maxilla. So what are the cells of an bone? It consists of osteoblast, osteocyte and osteoclast. Osteoblasts develop from mesenchymal stem cells and they convert to pre-osteoblast and then osteoblast. Osteoblast is a cuboidal cell with a single nuclei. And osteocyte, as I already said, it lie in a lacunae with canaliculi projected from all over the surface, whereas in case of cementocyte, it is projected only towards PDL. So by that we can differentiate an osteocyte and an cementocyte. Whereas osteoclast will arise from the hematopoietic stem cells, which is converted to monocyte or macrophages, and pre-osteoclast, leading to the formation of an multinucleated cell. So osteoblast is a basophilic, plump, cuboidal or slightly flattened cells. These osteocyte will be seen in more in woven bone and repair bone, which have 25 years of average life. And osteoclast will lie in a house-shaped lacunae and it is multinucleated and it contains acid phosphatase. So moving to the reversal and resting line. Resting line is nothing but the incremental line, that is regular rhythmic deposition of bone. Rhythmic deposition of bone, hence it is regular. Whereas irregular is the reversal line, which depicts the clear distinction between the formation and resorption, and it is also basophilic. So when we view it under the microscope, we can clearly find the difference between the reversal and the resting line. What is bone remodeling? That is sequential bone formation and resorption, which is necessary for the bone growth, is known as the bone remodeling, which involves osteoblast, osteoclast. So the bone either to form or to resorb were decided by the osteoblast depending upon the receptors what it is showing over the surface. So the osteoclast consists of rank and osteoblast consists of rank L. So when there is an synergistance between the rank and rankel, or when they both join, there will be formation of resorption. And formation, it is reversed and again formation is formed because of the presence of OPG, that is osteoprotogrin on the osteoblast, which will break the bond between this rank and rankel and hence leads to formation of bone by the osteoblast, which leads to the extended mineralization. That is, it is the sequential formation and resorption of bone. So, density of alveolar bone changes. It starts from D1 to D4. The D1 consists of fully cortical, D2 which will have coarse trabecula covered by thick cortical, and D3 is fine trabecular and thin cortical, and D4 consists of only trabecular. Now moving to the functions of alveolar bone. It supports teeth, that is, it makes the teeth to lie in a socket which were provided, and it provides a framework for the bone marrow. Especially it is the reservoir for ions, that is calcium, and it distributes the occlusal forces equally during mastication. And clinical implications, orthodontic tooth movement, again and again the cementum, PGL and the alveolar bone play an important role in the orthodontic tooth movement. The resorption of alveolar bone occurs upward and inward in case of maxilla, and in case of mandible it is downward and outward. Upward and inward in case of maxilla, downward and outward in case of mandible. Then there is something called graft, which is autograft, allograft or xenograft. Autograft when it is taken from the same human, and allograft which is taken from the other human, and xenograft which is taken from the other species. Fenestration is when the bony coverage has a defect. So, it is covered only by periosteum and gingiva. When the dehiscence is where when it is extends to the marginal bone, it is called as dehiscence. So, these are my references. Thank you. Hi everyone. Today's topic is tooth and its supporting structures. Tooth consists of enamel, dentin, pulp, cementum and supporting structures alveolar bone and periodontal ligament. Moving to enamel. Enamel is an epithelially derived protective covering of tooth and it is the most highly mineralized tissue in the body. It is unique because once it is formed, it is not formed again in the lifetime. That is, the enamel forming cells, that is the ameloblast, are lost once the tooth erupts into the oral cavity and it will not renew. And this highly mineralized tissue, which is formed by the matrix proteins, once the enamel has been formed, the entire organic matrix were removed as bulk. So, these are the two features why enamel is unique. Moving to the physical characteristics, the enamel consists of 96% of inorganic, which comprises of hydroxyapatite crystals, that is calcium, phosphate and carbonate ions. And traces of selenium, lead and fluoride were formed if these elements, these trace elements were present during the formation of an enamel, and consist of 4% of organic material. Dissolution of these ions leads to the formation of dental caries. This provides the chemical basis for the dental caries, and this high mineralized tissue helps the enamel to withstand heavy occlusal forces during function. And the color varies from light yellow to grey white. It is generally translucent. The thickness varies from 2.5 mm on the occlusal aspect to the feather edge at the cervical area. So, structure is very important. The fundamental organization of an enamel is composed of rod, interrod, which is surrounded by rod sheath. Rods will be cylindrical in shape with crystals arranged parallel to the long axis of the rod, whereas interrods surround the rod. Okay, it surround the rod and the orientation of crystals will be different than that of the longitudinal axis of the rods. So, the rods and interrods together will give you a keyhole appearance like this. And enamel, so enamel comprises of a long ribbon like crystals which will be 60 to 70 nanometer in length. That is, the length spans the entire thickness of an enamel layer. Moving to the direction of enamel rods, how these enamel rods were present in the deciduous and in the permanent teeth. So, in the deciduous teeth, in the cervical and middle third, it will be horizontal, okay, and it will be oblique in the occlusal third, and in the cusp tips, it is almost vertical. Whereas, moving to the permanent teeth, in the cusp tip, it is again vertical, and in the middle third, it is horizontal, and in the cervical, it will inclined towards the root. So, here you will have the root. So, the rods will be inclined towards the root in the permanent teeth. Moving to amelogenesis. Amelogenesis is nothing but the formation of enamel. It will occur in two processes. The first is the initial mineralization, where it is mineralized only up to 30%, then it is mineralized to 96% by the concurrent accretion of the minerals. Ameloblasts have a unique life cycle which is characterized by progressive phenotype change, that is, it will have its own primary activity throughout each phase of the cycle, and they secrete matrix proteins that provides an environment favorable to mineral deposition. Moving to the light microscopy of amelogenesis, which is broadly classified into pre-secretory, secretory and maturation stage. In the pre-secretory, remember 4 P's, that is, the ameloblast will acquire phenotype, change polarity, and it has high protein synthetic apparatus, and it will permit or it will prepare the ameloblast to secrete the organic matrix. In the secretory stage, it will elaborate and organize the highly ordered tissue, and in the maturative stage, it will modulate and transfer ions so that concurrent accretion of mineral will occur. So, life cycle of an ameloblast consists of morphogenic stage, organizing, secretory, maturation, transitional and protective. will go through each stage. The first being the morphogenic stage, that is, the inner enamel epithelial cells will be either cuboidal or it will be low columnar with a centrally placed nuclei, and it will undergo mitosis. Golgi apparatus will be seen in the proximal area and mitochondria and other organelles will be scattered. Here this is the picture of a morphogenic stage ameloblast, okay, where the Golgi apparatus were in the proximal area and the other organelles were just scattered. Look at the size of the ameloblast, which is either cuboidal or low columnar. Moving to the organizing stage, now you can see the difference in the size of the cell. So, the nuclei will shift proximally with mitochondria. Golgi and centrioles will be present distal. One more important thing is the inner enamel epithelium will be polarized, that is, it will not do not divide after this, and there will be formation of odontoblast differentiation, that is, as soon as the inner enamel epithelial cells polarized, it will interact with the dental papilla cells and differentiate into odontoblast. Thus, the acellular zone which is present will disappear at this process. Then these ameloblasts will come closer together by the formation of a specialized structures called junctional complexes. It will be present both in the distal and the proximal end, namely distal junctional complex and proximal junctional complex. And these junctional complexes will have something called actin filaments, which will radiate from here to the cytoplasm of the ameloblast, and then it will form something called terminal web. What is the purpose of this terminal web is, it makes the ameloblast remain attached together till the formation of an enamel, and this also decides what's to go in and what to go out of an enamel during its formation. Moving to the secretory stage, as the name suggests, it reflects intense synthetic and secretory activity. So, the enamel proteins were packed in secretory vesicles, okay, and they have been thrown out into the distal Toombs process and it will lay down enamel. The first formed enamel will not have any rods or interrods. It is the first formed enamel which is formed away from the dentin, against the dentin, and the whole ameloblast will move away once the enamel has been formed, and the proximal surface will lead to the formation of something called enamel partition, that is interrods, something like this, which will have a pit, and there will be a partition that is present like this, and the distal part will form rods which will be filling this pit. That is, these outer layer, that is the partitions will be formed by the proximal and the inner pit will be filled by the distal, contributing to the rod and interrod. So, this picture clearly depicts the interrod from the proximal surface and the rod from the distal surface, and this is the proximal surface where the interrod is formed. So, interrod is formed ahead of rod. Moving to the maturative stage. Maturative stage is nothing but the growth of the pre-existing crystals. So, when the growth has been occurred, there will be a bulk removal of matrix proteins, as I have already mentioned. This is the unique feature of an enamel, that is the whole mineralization, that is the whole, after the whole mineralization, the maturation occurs by the prolonging the width of the crystals and removal of the matrix protein. And there is a stage called transition where the ameloblast will reduce in size and the organelles will also be reduced, undergo programmed cell death, that is 50% of ameloblast will undergo programmed cell death during its transitional stage and other 50% during the final maturative stage. There is a special feature, something called modulation. Modulation is nothing but cyclic creation, loss and recreation of highly invaginated ruffle-ended apical surface. That is, the ameloblast will be changing from, this is the ruffle-ended, will be changing from the ruffle-ended to smooth-ended, which will occur once in 8 hours. Okay. What is the use of this? Due to the formation of the enamel, that is due to the formation of more minerals, acidification occurs. So, this ruffle-ended will secrete bicarbonate ions. which will alkalizes the enamel fluid, thus preventing reverse demineralization. So, modulation is one of the main important process which occurs within the ameloblast to maintain the alkalic nature of the enamel fluid to prevent reverse demineralization. So, moving to the differences between ruffle-ended and smooth-ended. In the ruffle-ended, the leaky region is the proximal surface, whereas in the smooth-ended, the leaky is the distal surface, and the tight is the distal in case of ruffle-ended. Here the tight is the proximal in case of smooth-ended. Ruffle-ended leading to incorporation of organic material, and smooth-ended will help in the exit of protein fragments and water. And the change of ruffle-ended to smooth-ended and smooth-ended to ruffle-ended is known as modulation. Moving to the final stage, that is the protective stage. In the protective stage, again have a look at the size of the ameloblast. It has reduced in size, and these ameloblasts along with the papillary layer combine to form something called reduced enamel epithelium. As the name suggests, the ameloblast reduce in size. Okay, it is protected until the tooth erupts into the oral cavity, and once it is erupt into the oral cavity, it interacts with the oral epithelium to form something called junctional epithelium. Hence, the amelogenesis is nothing but initial partial mineralization and subsequent maturation with the increase in the width of the crystals with bulk removal of enamel proteins. So, enamel proteins which play a main role in the formation of an enamel consist of 90% of amelogenin and 10% of non-amelogenin. So, this enamel lysine, kallikrein, amylotoin and apin were few of the non-amelogenin, where enamel lysine belongs to matrix metalloprotease family. And it helps in the short term processing of newly secreted matrix proteins, and kallikrein 4 belong to serine protease family, and it is the bulk digestive enzyme, that is to remove the organic matrix. Then comes the amylotoin and apin. As the name starts with A, it is present in the apical surface of modulating ameloblast, and hence it helps in the adhesion of enamel organ to the ameloblast. So, everything starts with A, so it is easy to remember amylotoin, apin, which is present in the apical surface of modulating ameloblast, and it helps in the adhesion of enamel organ to the ameloblast. Moving to the mineral pathway and mineralization, which is very unique because it does not have matrix vesicles, which plays main role in the mineralization and maturation of collagen based calcified structures such as dentin or bone. So, there is no equivalent formation of predentin or osteoid here in enamel. It is just the direct formation of crystals over mantle dentin. So, then how come the calcium just passed through the enamel? It is passed through the enamel with the help of an endoplasmic reticulum, and there will be smooth sinusoidal pores through which the calcium gets into the enamel surface. So, finally, the enamel formation is something complex and diverse and also destructive. Why ameloblast should spend so much time in forming a highly mineralized structure with so much complexity, but there is no survival potential beyond the point of mineral induction still remains a puzzle. Enamel structure itself is complex because it is formed by the isoforms of the same protein, which leads to the bulk of the enamel. The final complexity were formed by the non-amelogenin. Okay. So, it is mainly the protein-protein interaction intracellularly, and as I already mentioned, there is no equivalent of predentin or osteoid were formed. It is just protein-protein interaction. Then amelogenin enzyme, and it forms new crystals which leads to the expansion of the enamel layer. Once the crystals were spatially arranged. The final expansion occurs something called volumetric expansion, which occurs after removing this amylogenin in bulk, which has a mineral promoting activity. Now moving to the histological structures that is present in the enamel. The first one being the striae of Retzius, otherwise called incremental layer of Retzius, which is nothing but the weekly rhythm in enamel production or appositional or incremental growth of the enamel layer. So, the distance between each striae is 4 micrometer. Next is the optical phenomenon, and the first one being the Hunter-Schugert bands. It is seen in the longitudinal ground section, and it is nothing but the alternate light and dark bands under incident illumination, which can be reversed by altering the incident illumination, and it is due to the change in the direction of rods. And next is the knarled enamel, which will be seen in the cusp tips, where the enamel rods will twist and they will have a complex arrangement. So, this is the picture depicting the direction of enamel rods from the DEJ to the enamel surface, and at the surface it is getting twisted up and produce a complex structure. So, this, and when we see it under the microscope, will give you a something called optical phenomenon, something called knarled enamel. And here this picture shows cut surface of 2 layer of prism. This is one layer and this is the second layer, and they are directed at different angles. Moving to the hypocalcified structures, we have something called enamel tuft and enamel lamellae. Enamel tuft will rise from the DEJ to the enamel surface, and it will have an appearance of tuft-like grasses, whereas enamel lamellae is a crack which appear from the enamel surface to the DEJ. Enamel lamellae is of 3 types, type A, B and C. The type A consists of poorly calcified rocked segments in the crack, whereas type B consists of degenerated cells, and type C consists of organic matter which is derived from either tooth or saliva. So, it differs by the presence of content in the crack. Moving to something called perikymata. Perikymata is nothing but transverse wave-like grooves. Okay, it is seen where incremental line of Retzius reach the outer surface of enamel. That is, we can simply call it as external manifestation of striae of Retzius. Moving to enamel caps and brocks. Enamel, the surface of an enamel is not even. So, it will have a dip and an elevation. So, dip is nothing but pit and elevation is nothing but broke. So, why there is a dip? It is due to the loss of something. So, what is lost? Ends of ameloblast after the formation of an enamel. Then elevation. Elevation means something is added up. So, what is added? Deposition of enamel and debris of the enamel organ is added. So, the surface of enamel is not smooth. It will be either pit or there will be either elevation. So, a picture just depicting enamel caps and brocks, that is pits and elevation. Moving to enamel spindle. Enamel spindle is nothing but the extension of odontoblastic process to the enamel surface before enamel or dentin is laid down, and it will be dark in transmitted light. So, here in this picture you can see numerous enamel spindles, okay, that is nothing but the odontoblastic process extending towards the enamel surface. Moving to the clinical implications, enamel hypoplasia. So, as the name suggests, there is defect in the matrix formation. So, there will be either thin enamel, either with pitting or grooving, or there will be total absence of enamel. So, this picture shows pitting of enamel, that is the brownish pits all over the enamel. Okay. So, this is enamel hypoplasia. And enamel hypocalcification, where there is defect in the maturation. So, this type of enamel will appear opaque or chalky areas as given in this picture. Moving to molar incisor hypomineralization, which will occur due to systemic illness during the formation of an enamel, and it will affect mostly the first permanent molar and incisor, that is forms within the first year. So, if any kid within the first year of life have any systemic illness, then this condition can be more common. So, this defect will break down since the enamel is very soft due to the masticatory pressure. So, patient will have a complaint of sensitivity. Fluorosis, when the fluoride in water exceeds more than 1.5 milligram per liter, there will be formation of fluoroapatite rather than hydroxyapatite. Then the fluorosis will appear such as white patches or brownish patches all over the teeth. So, it will vary from mild, moderate to severe. So, the critical period is the first 8 years. So, when the kid is overexposed to fluoride during the first 8 years of life, might have higher chances of getting fluorosis. Amelogenesis imperfecta, very common term. It is nothing but clinically and genetically heterogeneous group of conditions that affect enamel. Okay, it could be either X-linked or dominant or recessive trait. So, the trait could be hypoplastic or hypomineralized, or it might have both. Amylex, that is defect in amylex, leads to something called X-linked amelogenesis imperfecta, and defect in enamel lysine and kallikrein will have autosomal recessive pigmented hypomaturation amelogenesis imperfecta, and defect in amylotoin will also leads to formation of a genetic disease, that is amelogenesis imperfecta. So, this table clearly depicts the mutation in enamel protein, defect and their clinical appearance. Amelogenin, as I already mentioned, it leads to X-linked amelogenesis imperfecta, which will have vertical pits and grooves, and there will be vertical bands of alternating normal and abnormal enamel. Then moving to enamelin. Enamelin leads to generalized hypoplastic amelogenesis imperfecta, where there will be minor pitting to diffuse generalized thin enamel. Then moving to kallikrein 4. That leads to hypomaturation amelogenesis imperfecta, where the enamel will be white opaque with mottling, or they have brownish discoloration, and there will be regular chances of enamel chipping. Moving to MMP20, that is matrix metalloprotease 20, which also helps in the formation of enamel, and defect in this leads to autosomal recessive pigmented hypomaturation amelogenesis imperfecta. So, it will be mottled and characteristically have an agar brown appearance. The enamel fractures exposing the soft dentin. So, there will be higher chances of sensitivity, and one unique feature is this patients will have anterior open bite. Moving to the next hard tissue, that is the dentin. Dentin forms the bulk of the tooth. It is bone-like matrix which has odontoblast traversed throughout its matrix, and dentinal tubules with cytoplasmic extensions of odontoblast were present, and it almost have a S-shaped or sigmoid shaped dentinal tubules into which the odontoblast will be traversing throughout the length. Dentin consists of 70% of inorganic, 20% of organic and 10% of water. It is yellowish in color. The structure of dentin consists of peritubular dentin and intertubular dentin. As the name suggests, peritubular dentin delimits the tubule and it is highly calcified matrix, whereas the intertubular dentin is the one which is present in between the peritubular dentin, and this forms the bulk of the dentin, and this is the primary secretory product. Okay, and it is formed in between the collagen fibrils, that is mainly type 1. So, this type 1 collagen acts as a scaffold upon which this intertubular dentin is laid down. And there are few non-collagenous proteins such as dentin phosphoprotein, dentin xyloprotein and dentin glycoprotein, which will be closing the pores of the collagen fibers. All three will be depicted as a single molecule in the genome level, that is dentin silophosphoprotein. So, moving to the types of dentin, it is either primary, secondary or tertiary. Under primary, circumpulpal dentin which lines the pulp chamber, and mantle dentin which forms the outer surface of coronal dentin, and something called secondary dentin which is formed after the root formation. Deposition is much slower when compared to the primary dentin, and there is something called tertiary dentin which is formed only when there is stimulus such as a caries or any restorative material. So, it is only formed when there is a stimulus or when there is an irritation. So, the such type of dentin will not have a proper dentinal tubules. It might be either sparse or it is totally absent. And when the such type of dentin is formed from the pre-existing odontoblast, okay, we call it as reactionary, and when it is formed from the new odontoblast, we call it as reparative. And when these odontoblasts secrete this dentin, there will be few odontoblastic cells will be embedded in the dentinal matrix, and such type of dentin is called as osteodentin. Moving to the dentinogenesis. Dentinogenesis is the formation of dentin. So, it usually occurs in the Bell stage. Once the inner enamel epithelial cells reach its polarity, these papillary tissues, that is the dental papillar tissues, will start differentiating into odontoblast and starts forming dentin. And root dentin needs proliferation of Hertwig's epithelial root sheath from the cervical loop area. So, the first sign of dentin formation is the presence of large diameter fibrils, okay, which is nothing but Vohnkopf fibers, okay, and then the dentin is laid down over the fibers by the odontoblast, and they have matrix vesicles which is absent in case of enamel. Since these were collagen based calcified tissues, they all mineralize with the help of a matrix vesicle. So, in this matrix vesicle, mineral phase starts as a single crystal which will grow inside it, then break the confinement, and it will fuse with the adjacent crystals to form an homogeneous mass. That is how dentin is formed. So, this picture shows the proper production of dentin. So, these were the dental papilla cells which were just disoriented in the dental papilla, and the inner enamel epithelium, once it reaches the polarity, that is the amyloblast. So, here it is called as inner enamel epithelium. Once it reaches its polarity, we call it as amyloblast. That is, it will not undergo cell division after this. Okay. So, the formation of these fibers, Vohnkopf fibers, and the odontoblast will start laying down dentin. The first formed dentin is pre-dentin. Later, the odontoblast moves down as the dentin has been formed. Okay. So, how does the mineralization starts? As I already mentioned, there is an important structure called membrane bound matrix vesicles, and the mineral phase starts with a single crystal which will grow rapidly and rupture the confinement of the matrix vesicle. It will fuse with the adjacent crystals to form an homogeneous mineralized matrix. Pattern of mineralization could be either globular or linear. Globular calcification is nothing but the globules were fused together to form an homogeneous mass, whereas that pattern of calcification, when it slowed down or when it is organized, we call it as linear calcification. Okay, moving to the histological aspects of dentin. What are all the structures we can see under microscope? Interglobular dentin, which can be seen in the ground section when the globules fail to fuse and form an homogeneous mass, there will be formation of these black colored structures, okay, which will appear black in transmitted light. So, these were interglobular dentin. And then sclerotic dentin, when the dentinal tubules were filled with calcified material, it will appear sclerotic and it will most commonly seen in the old age people. Tomb's granular layer. The name suggests granular, but it is not the exact granule present over there. It is just the looping and coalescing of terminal branches of dentinal tubules that in ground section appear as granular layer, hence it is termed as Tomb's granular layer. And something called dead tracks, that is the occlusion of dentinal tubules by any calcified material leading to the dying of the odontoblast present there. So, it will appear black in transmitted light. Mainly it is associated with tertiary dentin formation, that is when there is any stimulus, the odontoblast coalesce and die. Moving to theories of dentin hypersensitivity. Dentin hypersensitivity is one of the main important symptom which many patients will come across. So, dentin is sensitive because it is exposed, but how does it is sensitive? There are many theories they have been formulated to explain the dentin hypersensitivity. The first one being the direct neural stimulation, which suggests that the nerve fibers which is present along with the odontoblast, this yellow color which is present along with the odontoblast will take away the pain sensation, and thus it is depicting it as dentin hypersensitivity. But again this theory is rejected because the nerve fibers were absent in the outer dentin, and when there is topical application of analgesics, it does not provide any symptomatic relief. Then comes the hydrodynamic theory, which is widely accepted theory. The dentinal fluid inside the tubules stimulate receptors in pulp, leading to dentin hypersensitivity. Then comes the transduction theory, which states that odontoblast act as a receptor and it will simulate the pain. But there is no neurotransmitter vesicles in the odontoblast and there is no synaptic relationship between the odontoblast and the nerve endings to perceive it as a pain. So, the only accepted theory is the hydrodynamic theory, which states that the dentinal fluid movement is responsible for the receptor stimulation in the pulp. Moving to the clinical implications. Dentinogenesis imperfecta. As amelogenesis imperfecta had defect in enamel, dentinogenesis imperfecta have defect in dentin, which is due to the mutation in the DSPP gene. It will affect both deciduous and the permanent teeth. So, it will have a light brown to light grey in color, and it appears like a tulip, that is the crown will be broader with much increased cervical constriction. So, it will appear like a tulip. Okay. In type 2, it is also known as shell teeth with multiple pulpal exposures. Then comes the dentin dysplasia, where you can see normal enamel but atypical dentin. It is of two types. In type 1, the roots were short and blunt and the pulp chambers were obliterated, whereas in type 2 it will have large pulp chambers. And radiographically there will be an appearance of thistle tube. The root appearance were referred to as thistle tube appearance. Then moving to the regional odontodysplasia, otherwise known as ghost teeth, which leads to the retarded eruption of most of the tooth. Okay. Here there will be normal enamel, but there will be increased predentin width and there will be more amount of radio-opaque structures in the pulp chamber, and there will be presence of interglobular dentin too, because there will be a defect in the fusing of the globules of minerals.